Good evening, everyone. It
Good
gives
evening.
me great pleasure to welcome you all on behalf of Orthopedic Research Society for this national webinar on a panel discussion on low back pain in patients with comorbidities, safety first. The Orthopedic Research Society, this society which is has been constituted to promote research. We organize webinars, conferences. We support our residents uh, for research grants and for travel grants. And it's really gives me great pleasure to start this very important webinar on the low back pain in elderly. And I would request Dr. Manjula to please set the ball rolling. Dr. Manjula, please.
Thank you very much, sir. Good evening to all of you. And it gives me immense pleasure to welcome you all to this very special edition of panel discussion on management of low back pain in comorbidities. I will be just showing you the agenda. The flow will be initially Dr. Malhotra sir will be giving the introductory remark. Then we will start about the panel discussion. I'm going to show you the panelists detail. Then we will be question and answer. Please, all of you, feel to ask all the questions in your chat box. Then it will be closed by vote of thanks from Orthopedic Society and Micro Knowledge Academy. So it's my privilege to introduce Dr. Rajesh Malhotra. I know sir does not require any introduction, but it's my formality to do so. It's my privilege to do so. Dr. Professor Rajesh Malhotra is the department head and the professor and head of the Department of Orthopedics, and he's chief of JPN Apex Trauma Center from the All India Institute of Medical Sciences, New Delhi, and he's a BC Roy awardee for the eminent medical teacher in 2014. He's a fellow and under revision joint replacement and bone banking at the Princess Alexandra Hospital, Brisbane, Australia. Sir has more than 900 publications in the Index Medical Journal, and he has been invited for more than 1,000 lectures on the national and the international forum, and he has edited more than 14 books, and he has written 61 chapters in this book. And third is the fellowship in advanced trauma from Germany, fellowship in Ranawat Orthopedic Center, senior traveling fellow from UK. Sir is also editor-in-chief of Orthopedics Today and convener of Orthopedic Initiative for Indian Society of Bone Mineral Research. He's been the past president of Indian Orthopedic Association and past president of Delhi Orthopedic Association and secretary of Regional Fragile Fracture Network of India. Sir, Professor Malhotra, it's pleasure and privilege to have you with us as a moderator, sir.
Thank you.
To introduce the panelists for today, we have Dr. Chanaraya sir, consultant physician and diabetes and clinical cardiologist. Sir is currently as the senior consultant and chief of cardiology at Bharati Nursing Home, Bangalore. He is also consultant at the Sagar Hospital, and sir has been the professor and HOD of prestigious Kempegowda Institute of Medical Sciences, Bangalore. Sir has been in the Society of Medical Education Research involved in extensive teaching of postgraduate students. He is a fellow of Indian College of Cardiology, fellow of Indian College of Physician. He has done more than 18 original research studies and many paper publication in cardiology, diabetes, and various national and the international journal. He's been given the Excellence Service Excellence Award from the Rotary South India, as well as Physicians Award in the year 2025, 2015 and 16. Professor Dr. Chanaraya sir, welcome to the panel, sir.
Sure.
Then we have Professor Dr. Rajesh Mahadevan sir. Sir is a senior consultant geriatrician and physician from Bangalore. He's been done his courses in various India as well as abroad. He is currently senior consultant and high super specialization in geriatric from David Griffin School of Medicine from USA, member of British Geriatric Society, member of American Academy of Family Physician, American College of Cardiology, and life member of Indian Medical Association. He has delivered many lectures in national and international conferences, scientific session and workshop in geriatric at AAFP and ACEP in USA. He has chaired several sessions, to name a few, Asian Pacific Pneumococcal Disease Conferences at Singapore, and he's been speaker and chair at several international conferences, to name one, the recent one, Asian Pacific Geriatric Conference in Cebu. Sir has been the member of Hunger Project, which is a WHO UNICEF initiative and winner of many national and international award on humanitarian service. Dr. Rajesh Mahadevan, sir, it's a pleasure and privilege to have you as a panelist, sir. Welcome to the panel, sir.
Thank you so much. Thank you.
Then we have Dr. Thank you, sir. Dr. Rajiv Raman, sir is a MS orthopedician from Consultant Orthoscopic Orthoplasty and Trauma Surgeon, Joint and Bone Care Hospital, Kolkata, Fellowship in Arthroscopy and Sport Medicine from UK, Fellowship in Foot and Ankle Surgery from National University Hospital, Singapore. He's been the Honorary Secretary of West Bengal Orthopedic Association, Honorary Secretary of West Bengal ASM, and Chairman of Inland Fellowship IOA, and Chairman of IASR Coordination Committee. So, Dr. Rajiv Raman, sir, again, welcome to give you the orthopedician perspective on this panel. Welcome to you, sir. Then we have Dr. Sanjay Kumar, sir. He is an MS and orthopedician, associate professor from Department of Orthopedics, Bhagatpur Singh Government Medical College for Women, Sonipat, Haryana, India. He has more than 12 years of clinical and academic experience, more than 25 publications in various national and the international indexed medical journals. He's published paper in the management of low back pain associated with this muscle spasm in International Journal of Applied Basics and Medical Research, which is a PubMed index journal, and he has been the speaker in several conferences, both India and the international forum. So, Dr. Sanjay Kumar, sir, it's a welcome and pleasure to have you with us, sir. We have Madam Dr. Seema Rani. She is MD Pharmacology, Professor and HOD of Department of Pharmacology, Bhagatpur Singh Government Medical College for Women from Haryana, India. She has rich experience of in pharmacology and clinical pharmacology, more than 17 years of experience, more than 40 publications in various national and international journals. She has published papers in the management of low back pain and associated with muscle spasm in International Journal of Applied and Basic Medical Research, which is again indexed medical journal. Madam, Dr. Seema, madam, it's pleasure and privilege to have you with us as a pharmacology specialist on this very important topic of managing low back pain in comorbidity. Welcome to you, ma'am, to the panel.
Thank you. Thank you. Thank you.
So with this, I would hand over the session to Professor Dr. Malhotra, sir. I request you to kindly take over the session and moderate the session, sir. Over to you, sir.
Thank you very much, Dr. Manjula. So I think in the next 15 minutes or so, I'll set up the context and get the ball rolling. I'll just make a presentation on the various aspects related to the back pain in the elderly patients, the patients with comorbidities. So this is the topic for today's webinar. And the low back pain is the modern day pandemic. It's the first most common cause of disability in young people, second most common cause of physician visits, third most common indication of surgical procedures, and the fourth most common reason for hospitalization. So back pain can actually affect anyone, anywhere, and anytime. The global point prevalence of low back pain has been reported to be 7.3%. It affects more than 500 million people in the world at any point of time. The leading cause of disability worldwide in terms of 60.1 million disability adjusted life years every year. If you look at the prevalence of low back pain and sciatica in adults, any kind of low back is prevalent in 60 to 80% of the population, and any low back pain lasting more than 2 weeks is 14 to 16%, whereas the back pain with features of sciatica lasting more than 2 weeks is 1.8%, and 1.2 or 1 to 2% population may have had the lumbar spine surgery of some kind. This is the global burden of disease study in India. And you see from the year 2007, when it ranked number 5, in 27, it became the third most common disease in India, ranking only after dietary iron deficiency and headache. So that's quite a leap from number 5 to number 3, and it says that it's a percentage change is almost 25% compared to its ranking on the 2007. For most country, interestingly, excluding India, in the world, low back pain is the leading cause of years lived with disability, because the workmen's compensation and the other reasons to avoid work are much more in the developed world as compared to India. So when is a low back pain chronic? A low back pain problem that has persisted at least 3 months or has resulted in pain on at least half the days in the past 6 months is called as the chronic low back pain. The pain becomes chronic because of the activation of inflammatory chemical pathways or the nerve receptive pathways, alteration of central neuroplasticity in the brain, and the peripheral sensitization of the pain receptor. So from a symptom of pain, it changes to a complex disease condition when it has continued for a long time. And we know that the structural changes take place in the spinal cord, which are somewhat irreversible. So like Hippocrates said, from the brain alone arise our pleasures, laughter, and jests, as well as our sorrows, pain, and grief. So what about the management? Now, non-operative management, is it an exception or a rule? More than 90% of the patients with chronic low back pain can be managed non-operatively. It's the first line of management unless there's an indication for emergency surgical intervention. For the vast majority of people with low back pain, it is currently not possible to accurately identify from where the pain is actually arising. There was a very famous trial, the Spine Patient Outcome Research Trial, or SPORT, which included 11 clinical centers in the United States, which did 3 simultaneous RCTs on disc herniation, spinal stenosis, and degenerative spondylolisthesis. And they compared surgical with the non-surgical treatment. There was a parallel observation cohort observed for a minimum of 24 months. In disc herniation, the SPORT trial showed that both groups improved substantially over a 2-year period. And then, although the study was limited by a large crossover, but then, it is something which we have known in clinical practice that most of the patients with lumbar disc herniation will actually get relief of pain, and maybe year or 18 months down the line, they are as good or as bad as the patient treated surgically. The lumbar stenosis and spondylolisthesis have, however, been shown to have better improvement and greater benefit in pain and function in surgically treated patients. Now, for managing the chronic low back pain, the education remains most important. So reassurance about the self-limiting natural course is important. Investigations are largely unnecessary. In fact, I would like to bring it up during the discussion as to when you should really ask for investigation. And there's very interesting study coming up a few slides later in my talk about the role of MRI. You must make the patient understand disability and learn to cope with it. You should encourage them to do activities and do not over-investigate. Now, this is a study which showed the catastrophization effects of an MRI report on patient and surgeon and the benefits of clinical reporting. And essentially what it said was that when you get an MRI done for a patient with back pain, it produces a negative perception and poor functional outcome in low back pain. You should order low back pain, MRI in low back pain for very specific indications, particularly if you want to operate, if you think there's going to be an operable cause, because it is a sin to operate on a patient's spine without the MRI. But then if it is not going to make any difference to the management, you are better off avoiding it. The rest is one of the important strategies. Restricted activity, job modification, and bed rest is usually not recommended except for acute disc herniation with disabling pain. That too for not more than 2 to 3 days. And that too is not absolute. You allow the patient to get up and walk around, go from one room to other, or use the toilet and not use a bedpan. The heat therapy increases the blood flow, metabolism, and elasticity of the connective tissues. You can use hot water bottles, hot water bags, hot towels, or hot baths, etc. It's useful in subacute pain, but there is limited evidence to support it. Cold therapy causes reduction in pain, blood flow, edema, inflammation, muscle spasm, and also reduces the metabolic demand. You can use ice, cold towels, cold pack gels, ice packs, or ice massage, but there is insufficient evidence to support its use. So whether to use heat or cold therapy. So this has been studied in 9 trials involving 1,117 participants. There is moderate evidence that the heat therapy provides a small overall short-term benefit in acute or subacute low back pain. Evidence for cold treatment is limited, and there is insufficient evidence to prove which one of them is really better. Exercises can be aerobic, strengthening, or stretching. They have a key role in persistent chronic back pain. They have a lesser role in acute back pain, and symptoms vary from symptoms from very severe or relief within a few weeks, which is the hallmark of acute back pain, is really doesn't need any exercise in the acute phase. It's actually more useful for the chronic pain. Now, there have been McKenzie's extension exercises, which basically the regimen focuses on flex posture leading to back pain. So the set of exercises promoted by McKenzie regime primarily aim at strengthening the extension movement. You can be lying prone and then lying on the elbows. A word of caution is that the patients who have the facet syndrome or lumbar canal stenosis, they actually can get worse with the extension exercises. So these are the flexion in sitting is a good exercise for them, whereas prone press up or standing extension is not good. Flexion in standing, if the patient can do it without getting very distressed, or flexion in lying, are very much on. So a systemic review of efficacy of McKenzie therapy for spinal pain showed that it results in greater decrease in pain and disability in the short term than other standard therapies, such as analgesics or general exercises, but there is insufficient data on long-term use. Now, there are Williams flexion exercises, which are based on the theory that evolution to erect posture led to redistribution of weight to the posterior aspect. Like I just now told you, that if there's a posterior overload, like facet syndromes, they can get worse with the extension exercises. And in such cases, you should aim to enhance lumbar flexion, avoid extension, and strengthen the abdominal and gluteal musculature by exercises such as pelvic tilt, partial sit-up, or single knee to chest. You can do double knee to chest, hamstring stretch, squat if your knees are all right, otherwise your knees will get worse. Seated flexion is a very good exercise without straining your back. You can do lunges again if your knees are not back. You should do core strengthening exercises, because when there are weak abdominals, this pelvis gets tilted like this, and then that causes the pain and the overstressing of the posterior element. So you must aim to strengthen the core, and that is a great help. So exercise therapy for treatment of non-specific low back pain has been shown to be slightly effective in this study in chronic back pain and to some extent in subacute back pain. And like I said, it's not very useful in acute low back pain. What about yoga? Yoga is a low impact exercise. It doesn't need any special equipment. It combines aerobic stretching and strengthening, posture and balance. There has been renewed interest in recent years. And in this Cochrane database, the yoga treatment for chronic non-specific low back pain has been studied. And it showed that yoga versus control evaluation showed better function and pain relief with yoga. Yoga with other exercises, the benefits were uncertain, and yoga was associated with more adverse events, that is to be noted. Now, what kind of mattress is to be used? The patient will often ask you. The firmness of the mattress affects the spinal posture while sleeping. So Kovacs et al. In Lancet published in 2003 a double-blind RCT of 313 adults, which studied medium firm versus firm, and they showed that the medium firm mattresses had better outcome. So when you have a bed which is too firm or a mattress which is too firm, there's excessive pressure on the shoulder and on the trochanter region. When it is too soft, it just digs. So there is too much of the curve downwards. So this one has too much of curve upwards. But when you have just the right firmness, the spine is almost straight when you're lying down. So that is the message from this study. The brace aim to correct the existing deformity or prevent progression. They stabilize and immobilize weak or damaged spinal segments, reduce axial load, and control movement. Various types of brace are there based on the extent of support provided. They can be supporting and stabilizing, basically in the acute phase to restrict movement. And in this particular study reported in Cochrane database, the lumbar support, there was moderate evidence that are not more effective than no intervention or training. So all these are, have limited the role and can at best be in acute pain for a couple of days or first few days in order to make the patient comfortable, particularly if they have to travel in that severe pain. What about the electrical currents? Electrical currents are based on the gate control theory. which means that the electrical impulses will cause closure of the gate and inhibit other pain, another pain message. There are different nerves are stimulated at different frequencies, the sensory, motor, and those which are when patients who are being given opioids. We have TENS, the transcutaneous electrical nerve stimulation, which are higher frequency currents which cause direct stimulation of deep nerve and spinal segments, and interferential therapy, which gives medium frequency waves and produce varied frequency for the deeper tissues. The electrical currents have been studied and their effectiveness has been shown that they reduce pain. Both of them are similar. There's nothing to choose between the two, but then the difference between the placebo and these is there, but not significant. Must keep that in mind. The microwave diathermy are electromagnetic radio waves. They selectively absorbed in tissues with high water content, such as muscle, and they heat the deeper tissues. But in this particular study, it showed it doesn't have much of a beneficial effect on the clinical parameters. What about the injections? You can have epidural injections, facet injections, sacroiliac joint injections, and selective nerve root blocks. The epidural steroids are given if the surgery needs to be avoided. For example, in pregnant ladies or elderly patients, it can be given by interlaminar, caudal, or transforaminal route. They have short-term benefit, no long-term route. The facet joint injections are used where you diagnose facet joints as the pain generator. These are synovial joints. The injections are given image-guided, as you can see here. They have short-term benefits, and you can actually also use the radio frequency ablation or the medial branch blocks to interrupt the pain arising from the facet joints. You can give sacroiliac joint injections, as has been shown here. It is used more often as diagnostic than therapeutic. And in a systemic review by Hansen et al. In 2012, it showed that there is poor evidence for short as well as long-term relief for intra-articular injection of steroids in the sacroiliac joint. The selective nerve root blocks are injection of both corticosteroid and anesthetic agent under fluoroscopic guidance. There is they have limited diagnostic value because the inadequate blocks and overflow is common. They have short-term therapeutic value. So in this particular paper, it said that the caudal epidural blocks is an easy and safe method with better short-term, mid-term, and long-term pain relief and improvement in functional disability than much more technique-intensive selective nerve root blocks. So what about the multidisciplinary rehabilitation and cognitive behavioral therapy? This is an umbrella term applied to programs that adhere to the biopsychosocial conceptualization of chronic pain and include more than just a physical treatment. It's a coordinated intervention covering several domains of the biopsychosocial model and delivered by clinicians from different backgrounds. So you will realize why I have put together a multi-speciality team, because a chronic back pain needs a multimodal or a multi-speciality treatment, and it's more effective than usual care. It has been shown, and so it's better than physical treatment in decreasing pain and disability in patients with chronic back pain. There has been something called the back school, and they were a big hype when I was training. Now they have been shown to be no effective or have a very trivial effect. Massage, interestingly, shows some improvements in the low back pain in short-term follow-up, and acupuncture is better than no treatment, and it is useful in the short term only. There are certain intradiscal therapy. I know it's a mixed audience. I will not go into much of the details about the intradiscal therapies, but just to prime you or sensitize you to the different therapies which can give for intradiscal cause of pain. They can be intradiscal electrothermal therapy, radiofrequency ablation, intradiscal ozone, cryotherapy, percutaneous endoscopic laser discectomy, or cell-based therapy. So basically, the electrothermal treatment actually damages the nociceptive receptors in the disc. You can do the same thing with the radiofrequency ablation, or you can actually interrupt the inflammatory cascade of arachidonic acid in the disc by using ozone, which actually increases the oxygen concentration. And you can use the cryotherapy or the percutaneous endoscopic laser discectomy. The cell-based therapy, including the autologous platelet-rich plasma or the tumor necrosis factor alpha inhibitors or the mesenchymal stem cells, all have been tried for this. But then, where is the evidence? The most definite conclusion from this particular paper said that there is no uniform consensus or on a procedure or procedures. The problems are because whenever you want to study the effect of any intervention on the chronic low back pain, the issues are the patient selection, the indications are limited, there is a lack of a gold standard diagnostic test, the patient population is often heterogeneous, the follow-ups are short, the like I already told you, discogenic back pain has benign history, may become all right by itself without telling whether it was really because of intervention or not. And then conservative treatment in many conditions gives the same results over long term as the surgical treatment. So you have seen the problems, the various interventions. They have shown poor results and poor reported literature. So we have to be resigned to the fact that it is the non-pharmacological and pharmacological treatment of and non-invasive treatment for the low back pain, which still remains the standard of care in the present day. So this is the problems which I mentioned. So these are the various pharmacological managements. We are going to address them: the analgesics, anti-inflammatory, muscle relaxants, antidepressants, anticonvulsants, and steroids. So my last slide is, before we go on to the panel discussion, in this particular report of US National Prevalence reported in 2007, the adult patients with low back pain were 1.8 times more likely to have a respiratory condition, 1.7 times more likely to have a coronary artery disease, 2.2 times more likely to have peptic ulcer disease, 1.3 times more likely to have diabetes, 1.4 times more likely to have hypothyroidism, and 2.8 times more likely to have large joint arthritis compared to healthy control. And there lies the challenge, and there lies the root purpose for this webinar, because not only we have to see what drugs can be given safely to these patients, but whether they will have any interactions or the adverse reactions with the co-therapy or the co-treatments with these patients are receiving. So once again, I welcome my distinguished panel, and we are all set to go. So I hope my panelists are all ready.
Yes.
Oh, great. So let's start this. So this is the epidemiology of the low back pain, and we just quickly mentioned it, that these the 540 million people all over the world are actually suffering from back pain, and the condition has actually doubled in last 25 years. And with aging of the population, it is much likely to get worse. So I would start with Dr. Sanjeev. Sanjeev, in your clinical practice, what age group of patients are commonly associated with low back pain?
So low back pain is mainly associated with elderly groups, sir.
Okay, that's I think you are taking over some of the patients of Dr. Rajesh Mahadevan, because he is the one who's the geriatrician on the board. So I thought maybe you will have some patient with collapsed intervertebral disc or the sprained back. But well, I mean, that's an honest answer. And so that is his question. So in this particular study also, the low back pain was reported to increase with age. In a longitudinal study which assessed 277 subjects aged 70 years at baseline over 7 years of period, it showed the incidence of back pain, which was 44% at the age of 70, increased to 58% at the 77 years of age. But mind you, I think more than 90% of the patients at the age of 77 years will have radiological evidence of spondylitis or lumbar spondylosis. So that really is not the proof that these patients will have pain. Otherwise, everybody would have pain. Dr. Rajesh Mahadevan,
Yes, sir.
in your opinion, which gender is more commonly associated with low back pain? Is it a problem of women or men?
Yes, it is more with women compared to that of the men.
So
Even
that's
over the last
actually,
so many years of the practice, I've seen even women above 40 years of age come starting with the low back pain in a very moderate way. And then as the age progresses, and if they have not taken any appropriate treatment, the chronic back pain increases, and then they land up with a lot of problems.
so do you think that it has got something to do with their lifestyle, household work, or they bend forward and they lift up buckets,
Or also, I think I would like to say that even from young age, probably, I mean, looking from an Indian scenario, that probably the nutritional aspects of the girl child have not been up to the mark. And that also could be the reason that they have not been having proper milk or curd. So the calcium deposits in the bones have been very less. And then with age, as they progress, they get married, they have children, and after that, some of them who are the homemakers spend a lot of time at home doing a lot of household work. That is a form of exercise, no doubt about it. But the nutrition aspect of the bones or the general health is not actually taken care of. So that can lead to back pain, excessive home work at home, or doing hard labor work, which women do in India, can also lead to low back pain. In the educated, yeah, yes,
yeah,
sir.
sorry, please complete.
In the educated society, of course, people who work can also have low back pain because of postural defects. They can also have low back pain because of obesity, which nowadays we see more in the younger generation. So I would like to limit my comments there because later on, as we progress, I would like to throw more light on what causes low back pain more in the elderly people in particular.
I think that was a great answer. And in this particular study, it showed that the females, the rural population, and elementary workers have much more incidence of low back pain. But I think since you brought up nutrition, I think it's very important for us to understand and realize that we do have a large proportion of elderly females who are suffering from osteoporosis. And because it's like he said, one factor is nutritional deficiency, which might include the deficiency of proteins, but also the osteoporosis, which can be genetic, and also the vitamin D deficiency. So whether it's osteomalacia or osteoporosis, particularly osteoporosis, giving rise to the hunchback, the kyphosis, or the crookedness of the back, or the kyphosis, which we very often see, puts the rest of the spine at the disadvantage. And I think that also should be considered, particularly if you see a lady who has been having a family history of osteoporosis, or who reports that her height has become less with period of time. That's very common. They'll say that the petticoats have become longer over a period of time, and their osteoporosis is related to their their back pain is related to their spinal deformity, which is in large number of cases arising from the osteoporosis. Is Rajiv Raman there? Oh, he hasn't joined, is it?
Yeah, I have joined, Rajesh sir.
Oh, so Rajiv, I welcome. I would like to know from you, as an orthopedic surgeon, what proportion of elderly females you see in your practice who have osteoporosis, or the hunchback, or the the thoracic kyphosis?
So normally in our clinical practice, I think we divide this low back pain patients into three groups. One comes with some history of trauma; those are the traumatic low back pain. You have a history of degeneration, which is very common. I think in my clinical practice, degenerative pain is very common. And last not least, in our Indian scenario, it's an infective pattern that you should rule out because tuberculosis is very endemic in our country. If you see that age group, particularly I think the degenerative age group, the 40 to 60 years, in those age group, you have lots of degenerative spine problem. And they come in our OPD with low back pain, sometime with or without radiculopathy.
Okay, so now that you are here, can you tell me, what do you think, in your opinion, is the role of paracetamol in management of back pain?
Yes, I think sometimes paracetamol alone or in combination is a very good drug. But the good thing of paracetamol is that you can give in medically compromised patients. Sometimes you have patients with hypertensive, diabetes, some amount of comorbid conditions. It's a very safe drug, and you can give it with long duration also. The best combination for me is either a paracetamol with a muscle relaxant or paracetamol with a tramadol group of drug. I think that is the best way combination therapy I use in my clinical practice. But yes, sometimes patient is not very much responsive, or sometimes the patient is have some amount of I think adverse effect of the drugs which are being combined with the paracetamol. Paracetamol alone can be used as an analgesic also.
So that is perfectly in keeping with the NICE guidelines, which says that oral NSAIDs, when you are considering for low back pain, you can actually must look at the gastrointestinal, liver, or cardiorenal toxicity. And this says if you have to use NSAIDs, you should actually use them the lowest effective dose, because that's what creates problem. And the most of the studies say that you are better off starting with the non-pharmacological treatment. We have a pharmacologist with us, Dr. Seema Rani. Dr. Seema Rani, if a patient with back pain has muscle spasm, and the patient is elderly, has comorbidities, so what kind of therapeutic approach would you recommend?
Sir, as we have low back pain patient with comorbid conditions, so I think we will prefer, because the muscle spasm is the major part, so we'll go for some of the centrally acting muscle relaxant. We have some traditional muscle relaxants like chloroxone, tizanidine, baclofen, thiocalcicide, and some newer one have come in the market. So we will we'll give the combination therapy, mixed combinations, either NSAIDs along with the muscle relaxant, but as NSAIDs are mostly contraindicated in most of the comorbid conditions, so we'll go for paracetamol along with muscle relaxant. But as muscle spasm, in case of low back pain, has some inflammation also, so we can go, if it's not relieved with analgesic like paracetamol, we can go with low dose NSAID also. Like maybe we can add brufen in certain cases, but always will take precaution and SOS basis.
Right. So we have Dr. Chennaraya with us. Dr. Chennaraya, what
Yes.
proportion of the patients in your practice with back pain have diabetes or the cardiovascular disease?
Now, quite more than 40 to 50% of the patients what we see do have either one of these comorbid illness, because in our country the diabetes prevalence is increasing, because our country is becoming the pandemic for the diabetes or endemic, and also the obesity, the second problem which is being added to the problem is obesity is also increasing in our country. Of late, for last 1 decade, we see even children coming with obesity, and diabetics, most of the diabetics are increasing to have obesity, and also the COVID has added as a factor to increase the obesity. So after the COVID, people have started the sedentary lifestyle, overeating. So all these are added. So many of the people are going to have this problem of low back pain. More so, they will have diabetes, or the other stroke problems are very common in these patients.
So now that we have you hooked on to this, do you mind telling me what are the issues of using NSAIDs in patients who are diabetics and the patients who have cardiovascular disease, or for instance, the patients who are on anticoagulants?
A problem with these patients who you mentioned, most of them would be on some of the antiplatelet drugs, either single or dual antiplatelet drugs. So most of them will be receiving some anticoagulants also for various cardiac issues if they've undergone recently some procedure or angioplasty or anything. So they will be on any of these drugs. So you have to be very, very cautious in choosing the drugs in such situations. So most often you have to have a checklist before you start NSAIDs to patients with low back pain, whether should we give. So all comorbid illness and drugs checklist should be done before you start NSAIDs. So you need to avoid NSAIDs in these patients for various reasons, being one is their chances of bleeding is very high in these patients if they're already on aspirin. Per se aspirin, or if they are on dual antiplatelet, GI bleeding is very, very common. So the risk of bleeding goes high when you add NSAID to such patients. So you have to be very careful in choosing the drugs for these patients. Ideally would be we go for paracetamol in such situations, or really you have to assess if required, you have to give for short duration of NSAIDs, maybe at a lowest possible dose if required, and try to avoid as much as possible NSAIDs in this patient so that you don't land up with bleeding complications or nephrotoxicity, or cardiovascular events are also going to increase if they have, suppose, hypertension or heart failure. So if you add NSAIDs, their heart failure worsens because the sodium and fluid retention. So the other issues of heart failure, worsening of hypertension. So these are very, very common when you add NSAIDs. If you add, you need to closely monitor, and if required, it is to be low dose and it should be really short duration. So many times I've seen being prescribed and they forget how long to mention in most of these patients. They continue to take because they get good relief and they go home, they don't come back to the doctor and they continue to take. So that is the other caution you need to have, whether patients should be educated and advised properly when you prescribe these drugs.
Sure. Dr. Seema, we had a lot of excitement when the COX-2 selective inhibitors were launched, and it was felt that now, that was the end of all our problems. And then we started realizing that highly selective COX-2 inhibitors like rofecoxib, they had the cardiac issues. So would you like to guide the audience about the limitations of COX-2 inhibitors and also the common interactions of the COX selective and COX non-selective analgesics with the commonly used co-prescriptions in elderly, like antihypertensives and like the cardiac medicines?
Yes, sir. Sir, as we all know that NSAIDs, they may be COX-1 or COX-2, but really, as you already told, that we were really excited when COX-2 came. But later on, it was seen that it's more going towards the cardiovascular toxicities and ischemic stroke side effects. So almost all are almost nearly banned nowadays, except one or two. So it was one of the cardiovascular morbidities, and another is even peptic ulcers. That are the condition which worsen these more. Then we'll come to in the conditions like severe cardiovascular morbidities, which is more common in elderly patients, and as along with hypertension. So as we are giving NSAIDs along with ACE inhibitors, so that leads to the hypotensive action of the ACE inhibitor decreases. As we all know that NSAIDs, that leads to the sodium water tension. Again, diuretics, as already most of the cases of serious, we are prescribing diuretics commonly by the physician. So again, it leads to the blunting action of the diuretics. Then beta blockers also, as it's prescribed, it also decreases the antihypertensive action of beta blockers also. So and all these reasons because leads to the increase in renal failure on prolonged use of these NSAIDs drugs along with the most of the drugs which we are using for the cardiovascular diseases. So again, the next on the comorbid patients, elderly, which are on the blood thinner drugs like warfarin or heparin, that enhances the bleeding tendencies. That is one reason because we are adding single therapy or the dual therapy of anticoagulants. Along with that, NSAID itself, it leads to the mucosal damage. So there are the more chances precipitation of bleeding. Then as we go on to asthma patients, again, asthma and COPD is one of the comorbid condition which is seen in the elderly patient. So that there are more patients which are sensitive to the NSAIDs, especially aspirin and other drugs for the asthmatic attacks get more precipitated. Then again, the certain person with comorbid conditions like cancer patients, they are on cyclosporin. So in this condition also the nephrotoxic action or the renal failure chances are much more in elderly patients. Then the diabetes, as already sir told, the chances of hypoglycemia that increases more when NSAIDs are combined with the our anti-diabetes drugs, especially sulfonylureas.
Okay. Dr. Sanjeev, you practice general medicine, and I would like to know from you that I know that your preference is for paracetamol, and there are good reasons for that. But in what group of patients which you treat with back pain, you are really concerned about using anything other than paracetamol, like the patients in which you will not like to use NSAIDs or tramadol or other drugs which are available?
So in case of the lower back pain, most common cause is the mechanical pain. So I think most common cause is the mechanical pain, sir, which is associated with the muscle spasm, sir. So you should always started with the analgesic or paracetamol with the muscle relaxant, sir.
Sure.
So either high corticoid combination, either closed oxygen combination. So analgesic or paracetamol should be started with the muscle relaxant, sir.
Great. And do you advise them some physiotherapy or some exercises as well?
Some physiotherapy, so it depends on the sir, which type of disease is present. So if there is flexion, in case of spondylolisthesis, in case of facial joint arthritis, in case of canal stenosis, flexion exercise are the best exercise, sir. So otherwise, we will otherwise extension exercise are the best. But in case of the canal stenosis, spondylolisthesis, facial joint arthritis, the flexion exercise are the best. That is pelvic tilt, knee to chest exercise. These are the best exercise for these are the flexion exercise. These exercise for these facial joint arthritis.
Sure.
Otherwise, we say that. I am saying that there are different type of exercise are present. Moreover, in which you have the benefit from the exercise that you have to do. Some patients benefit from the flexion exercise. Some patients benefit from the extension exercise.
Yeah, I think it also depends on if you are lucky enough to or smart enough to recognize the origin of the pain. If it is primarily arising from the posterior elements, will get worse with extension exercises.
In case of canal stenosis, in case of canal stenosis, the flexion exercise are the best, sir.
Yes. But in a slip disc, it's the extension exercise.
The extension exercise is the best.
So that is why the age is now. You are very right. Thank you for that. Dr. Rajesh Mahadevan, you are a pediatrician and your job is actually really very tough. So the old people often they have, we all know that there are psychological aspects. There are several dimensions to back pain in the old people. One is we know that any pain which goes on for 3 months leads to some depression, and a lot of people recommend adding some antidepressants to that. Secondly, I said that, when the pain has persisted for very long, actually the structural changes occur in the spinal cord, so that pain becomes chronic, and then it's almost impossible to get the complete relief. And thirdly, the old people often have social, economical, financial, psychological problems, whether they are being looked after by children or not. And all those make it very challenging to treat back pain in these patients. So do you suggest any psychiatric counseling or cognitive behavioral therapy in elderly patients with chronic back pain? Because, keep on giving analgesics or drugs without end is not really the long-term solution.
Right, Professor, I agree with you. In my practice, when I see elderly people who have been having chronic back pain, it is not just 3 months. They're probably having back pain for more than 3 years or even 5 years. They have been trying to take their own kind of treatment with their general practitioner, or they would have gone to some orthopedic surgeon who would have suggested various treatments, but when they have the fear of undergoing some operation or some kind of treatment, they take their own treatment from their GP and then they don't cure the problem. Then if they come to me knowing that a geriatrician could probably intervene a little differently, yes, as they already been having comorbid conditions, they will already be taking a lot of medicines either for blood pressure or for their diabetes. Over and above that, we have to add now some medicine to make sure that the pain is gone or reduced. Because they come with acute pain, they're unable to even walk from the waiting room into the chambers. So that shows how much of pain they are suffering with. Invariably, they will be obese or they'll be having other neurological conditions. They can be Parkinson's, they can be Alzheimer's, they can be even having a fear to walk because of old age, or they could be osteoporotic, or even osteoarthritis of the knee can actually prevent them from walking faster because of the pain in the knees. So there could be other additional features also in these people which will actually cause the back pain in them. Now, in the moment you want to say that you have to give one more drug, they first thing they tell you is, sir, please do not give us any more medicines. We are already taking enough and more. And the basic principle in geriatric practice is we have to give minimal medicines. We are not supposed to give more of medicines to anybody unless there is a chronic condition like an hypertension or a diabetes. And there also they have to be monitored more often than ordinary people of less than 50 years of age. So here we can tell them that this is not going to be a permanent cure. We can give them analgesics. We have to do some counseling within our chambers itself. We have to reassure them that over a period of time, there can probably be some relief of pain. We have to motivate them to start doing some little bit of walking. If they say they have osteoarthritis of the knee and they have pain in the knee joints, yes, we'll have to tell them that the medicine that I'm going to add is also going to give some relief of the knee joint pain. You can suggest using a local ointment for, then followed by hot water fermentation. That will give them some psychological relief more than the real therapeutic value of it. Plus, I always have seen in elderly people that I go and test them for vitamin D and vitamin B12. Invariably, doctor, I'm sure you will agree with me that 99% of my patients will have very, very low vitamin D and vitamin B12 deficiencies. And we have studied all these many years that vitamin D and B12 add on to the health of the individual. So in old people, especially women who are post-menopausal women also, for them, osteoporosis sets in much faster than men. And because of the obesity, they are developing this low back pain. So vitamin D deficiency will lead to further osteoporosis and calcium deficiency in the body. So that has to be corrected by giving them 60,000 international units once a week for 8 weeks, which is not much of a bother for them. Vitamin B12, I do not recommend tablets because that will not give them the immediate effect. So we have to probably give them a good injection twice a week for about 5 to 6 weeks and raise their vitamin B12 from 150 to about 700 or 800 over a span of 6 to 8 weeks. Once we do these two corrections with B12 and D, and then add one analgesic like a paracetamol tablet, I think more or less they come around in about 4 to 8 weeks of time. I do ask them to see me once in 2 to 3 weeks, keep giving them this a bit of counseling and reassurance, which is very, very important, or rather you have to keep saying, oh, you look better, you're walking better. We need to encourage them to make them feel better because they always feel bad about how they are given the present circumstances. So counseling will help. I do not recommend to give much of muscle relaxants, especially drugs like chlorhexidine. I don't never recommend. I have tried thiocolchicide at a higher dosage, but that had side effects. But now with 4 milligrams out in the market, I'll probably start trying that a little, but I will not go for tramadol because most of my patients have issues with tramadol also. So paracetamol, again, 500 milligrams alone was not doing the job. I've been trying to use paracetamol 650 milligrams even up to 3 times a day, and I got fantastic results because most of the time, doctor, these patients will have chronic gastritis, whether they agree or not. we can see them because they keep burping all the while when they are at the clinic. So you know that they have some form of gastritis. So instead of again adding one more PP4 and giving them more drugs, it is better to control it by giving a simple paracetamol tablet. In acute cases, yes, we can take the chance of giving them a very, very small dose, like an half BD tablet of colchicide, and maybe a mefenamic acid tablet would be better, more safer than using chlorhexazone. But as you said, overall, with all these B12, D, paracetamol, and suggesting some physiotherapy if they wish to do it, or wearing a lumbosacral belt, I think reassurance and counseling definitely puts them in a better spirit.
So those are some very, very useful points there. Just a quick word for the audience. The injection you heard was mainly about the B12. Please don't use injectable vitamin D. There are hardly any indications for using vitamin D injection, that too in patients with malabsorption syndrome or who have got some serious disorder compromising the absorption of vitamin D. Every now and then we see the doctors giving the vitamin D injections, and they actually can lead to the toxicity. Rajiv, I've got a quick couple of questions for you. Many of these patients have got neuropathic pain, and orthopedic surgeons sometimes add a small dose of gabapentinoids, as we call them. I agree with Dr. Mahadevan that tramadol relieves pain for some time, but then constipation and drowsiness can really become the big show spoilers. But when we give pregabalin or gabapentin, it does help some of them sleep. But then if they feel too drowsy, do you think giving them paracetamol can take care of some amount of centrally acting analgesic as centrally acting analgesic for the neuropathic component? Secondly, do you ever use the antidepressants or selective serotonin reuptake inhibitors in your practice? Hello? Hello? Is Rajiv there?
Hello. Yes, sir. Yes, sir. There's a network
Rajiv,
issue. Yes, sir.
I wanted to hear what is your opinion about the role of paracetamol for neuropathic component of the pain, and whether you ever use the antidepressants for the patients with, particularly with diabetes or peripheral neuropathy, who have backache, chronic backache along with it.
Yes, a very good question, and I think it's very pertinent in company to this discussion also. So normally, if you see the chronic low back pain, the etiology, it's very much related with some amount of the psychological issue also, and especially in diabetic patient also with the chronic low back pain, some amount of psychosomatic factor is also there. So I think use of antidepressant or use of neurotropic agent with paracetamol is a good idea in controlling these patients, controlling the pain. These only not contain it has the antidepressant does not only acts like an antidepressant also, and it has some amount of the neuropathic pain control also. So that is the main advantage of when you are using this antidepressant or a neurotropic vitamin with a paracetamol. So yes, in my clinical practice, often for chronic low back pain, I use antidepressant along with paracetamol.
So that is actually a very useful point. And I think I have a slide here for Dr. Sanjeev. Dr. Sanjeev, like you said, in this particular paper by Patel et al., published in 2019 in Pain and Therapy, the authors agree with your view that a combination of muscle relaxant with analgesic results superior efficacy. And I think if that analgesic is paracetamol, it actually adds the safety also to it. Your comments about that?
Sir, in case of lower back pain, there is efficacy and safety of paracetamol or analgesic with chlorzoxazine is better than any other drug, sir. Because
Sure.
in the in the low back pain, there is muscle relaxation muscle spasm component is all sometimes present, sir. The most common, I think, most common cause of the low back pain is the muscle spasm, sir. So some stiffness is present in the low back pain.
Dr. Sanjeev, you can also tell me what in your practice is the role of paracetamol if these elderly patients also have the osteoarthritis of the knee along with the low back pain.
So in case of the osteoarthritis is a degenerative condition. So in this case, some anti-inflammatory action is not required. So paracetamol is good analgesic, but not an anti-inflammatory. So there is good role of the paracetamol in osteoarthritis in elderly patients, sir.
So this is a study by Makelt et al. And where they looked at over 24,000 patients with knee and hip osteoarthritis. And they said that these are the patients, almost 58% of them take analgesic and most commonly paracetamol. So we have to be very cognizant of the fact that in India, many of these painkillers are available over the counter. And the patient, elderly patient may buy an NSAID or something which is not safe for his kidneys or does not respect his comorbidities and can be very dangerous. And I also like the idea, which was floated by Dr. Mahadevan, that we often also tell them to sparingly use the local topical treatment because that also gives them relief. And of course, the effect of the paracetamol in depressive disorders is also very good. This is a question again for the geriatrician and the orthopedic surgeon. We get old dementia in old patients, right? And they are very often prone to falls and they get hip fractures. Now, first the geriatrician, then the orthopedic surgeon, because these days we say that the hip fractures are best admitted under geriatrician who can optimize the patient for surgery. The orthopedic surgeon can operate, and then the geriatrician can better manage the post-operative condition because the delirium is common, the electrolyte imbalance is common. They can get into congestive failure. What about these elderly patients with hip fracture? Dr. Mahadevan, a quick short answer about that.
Sir, in very elderly people with pathological fractures or who have broken their spine by just a meager fall, again, we have to use some painkillers because the pain will be excruciating. Some of them will undergo the hip replacement surgery, some of them will not. Some of them will just end up, on a bed with a sling or a plaster. But I have found one very interesting item that I use in my practice for people with such issues. As you're all aware, when COX-2 inhibitors were launched across the globe and in India also, we were very excited about it because it used to give a lot of relief to the patients. But very soon we realized that COX-2 inhibitors have got a lot of cardiac problems. They cause arrhythmias and things like that. And in my study over the span of last 15 years, I have been doing some research on vitamin E. Now, vitamin E has got two components. One is the alpha tocopherol and one is the tocotrienols. Tocotrienols have got both COX-1 and COX-2 inhibitory properties. I have used tocotrienols to a very great extent in my patients who have had these kind of problems. I've recommended them to the orthopedic surgeon also who treats the patient, and they have got tremendous relief of pain along with paracetamol tablet. So once again, I would always choose the safer route of treating them. Maybe they will have pain for a little more duration compared to others, but I will not risk giving them any other medicine. Maybe, yes, a little bit of aceclofenac sodium is given, half a tablet or once a day or twice a day. But I would say if we can use paracetamol along with tocotrienols, that is vitamin E, we can get very, very good effect of the pain relief, because both the tocotrienols have got COX-1 and COX-2 inhibitory effects.
Dr. Rajiv Raman, orthopedic surgeon, you get a patient with hip fracture in emergency. And so what are your strategies for these patients?
I think, yes, sir, this is a very common scenario. You get a elderly patient with a hip fracture. The paracetamol is very good. I think paracetamol alone is not a very good analgesic. So I think always I try to put them with a combination, because paracetamol, sometimes we use 1 gram TDS also for elderly patients. So in those patients, you can use paracetamol alone, but if for fracture cases, I think you can add opioid also with paracetamol, so that you should have a better pain control.
I agree with you. Just a couple of editorial comments. One is that, something which is unfortunately not practiced very commonly in India, but fascia iliaca block. In our trauma center, even the nurses have been trained to give fascia iliaca block. So that is a good strategy for hip pain. Injectable paracetamol is another good option. I agree with you that we have to give them opioids or sometimes fentanyl or tramadol, but then the problem of the opiates and even tramadol, the problem of constipation and drowsiness, like I said, they particularly the constipation that can get very troublesome in elderly patients who have not been walking around. Dr. Chennaraya, a lot of people have a lot of apprehension about paracetamol and the liver disease. So, or, even normal liver, you will hear telling that, the paracetamol damages liver. So what is your take on, the use of paracetamol in patients, say, who are alcoholics or abuse alcohol or who have a liver disease? What's your take on that?
Paracetamol up to a certain dose, it is safe even in patients with liver disease. We can use for the patients who come for these analgesic effect, the dose what we use will be safe in these patients. Unless they have severe acute liver failure, then probably you have to be very careful when you are using the paracetamol. Otherwise, it is quite safe even in patients with those are alcoholics or even the other liver disease. So acute liver disease, you have to be careful where it is fulminant liver failure. So you cannot use it in such situation. Otherwise, the dose what we use is still safe in these patients.
I totally agree with you, and I'm happy I don't have to see these patients. But I think if you were treating a patient with liver failure, the pain will be the least of his problems. That pain will be a greater pain for you. But then it is said, it's recommended that you should not go more than 4 grams in patients who have compromised liver function. And it's also said that if any patient is taking more than 3 alcoholic drinks in a day, you should keep the dose of paracetamol to say maybe 2 grams a day in order to keep that possibility to the minimum. But then, of course, it is still paracetamol still remains the safest analgesic in the presence of kidney disease, in the presence of liver disease, and even in the presence of heart disease, and for Dr. Chennaraya's patients who are diabetics. So that is the another thing. So you touched upon it quickly, Dr. Seema, but can you just tell our audience, this is the last question before I ask each one of you to give a take-home message. It's the second last question. I still have to ask one more question from Rajiv, and then we'll go on to the message from each one of you. But then, Dr. Seema, which are the drugs which aggravate hypertension? Which are the drugs which aggravate asthma? So that our audience keep away from those drugs in elderly people.
Sir, NSAIDs. NSAIDs are the drugs which can exacerbate the asthma. The patient already have the history of asthma. So in that, especially aspirin hypersensitivity is very common. Even in elderly patient, if we are putting the patient on low dose of aspirin, then also there is a chance of precipitation of asthma. So we should take care of take care while giving these drugs insides especially. Then about the second you have told about the hypertension.
Yeah.
As already the patients on hypertension, if they're taking the NSAIDs, they can because of NSAIDs leads to the sodium water retention that may lead to aggravate asthma. That aggravate the cardiovascular diseases, especially the hypertension, even though if the patient is on ACE inhibitors or beta blockers, or we can say on diuretics.
Great. But I think I would just add one thing, that if you are constrained to use NSAID, then possibly naproxen is one of the lesser evils. Rajiv, what are the red flag signs in a elderly patient with back pain? And I want you to tell our audience not only the red flag signs, but which is the patient they should refer and not keep it themselves. Tell them that you need to see an orthopedic surgeon because this may be serious.
Very good question, sir. I think the red flag sign is important. And as a general practitioner and in pain management, all of the people, whenever your patient having a chronic low back pain, is having some urinal problem, stool problem, or this such type of patient comes with your cauda equina type of syndrome, it's an urgency. Try to refer to the orthopedic surgeon, because these are the red flag signs: sudden neurological deficit, sudden weakness of the lower limb, difficulty in urination, or sometimes they may be dysuria also, sometimes they may be difficulty in stool passes also. These are the signs. When you get this patient with this sign, ask them to be seen by orthopedic surgeons, so that after proper investigation we can go for, or we can plan for some type of surgical management.
So that is a great answer. Just want to remind our audience that the sudden onset neurological deficit, sphincteric involvement, sudden onset severe pain could mean an osteoporotic fracture in an elderly lady. Remember that there is something called multiple myeloma, which can involve the back and cause backache. Remember that there is something called metastatic bone disease, which could be a metastasis from anywhere else in the body, and it could be primary sitting somewhere and causing destruction. So if you see any deformity in the spine, if it's a recent onset, if the patient is cachexic or has the systemic symptoms and anorexia and weight loss along with backache, I think you should be very careful about these patients, and they must be looked at and investigated thoroughly. So now, gentlemen, it's time for one key recommendation or advice from each one of you to our audience. We'll start with Dr. Sanjeev. Dr. Sanjeev, what would you like to give a key take-home message to our audience today from your side?
Your message: never prescribe the NSAID for longer duration of time, sir. If you want to prescribe NSAID, should be for the shorter duration of time and medium dose, sir.
So that's a very, very sensible message, because if it's, say, osteoarthritis knee or lumbar spondylosis or lumbar canal stenosis, you are not planning to give the medicine to the patient for the rest of his life. And the longer you use a drug, it starts losing its efficacy, and you start, buying its side effects. Dr. Seema.
So, by choosing the drug in patient with comorbid conditions, with low backache, safety is our first priority. I think first priority of our physicians are don't harm the patient. Unless if the drug is not beneficial, at least don't harm the patient. So always in these patients, select the drug very cautiously and its dose also.
Great. Dr. Rajiv Raman.
What is important, I think, as an orthopedic surgeon, what Rajesh sir asked the last question: whenever you see the red flag sign, don't forget to refer an orthopedic surgeon, because sometimes it's a medical emergency for that patient.
Great. Dr. Chinnaraya.
So patients with comorbid illness like heart failure, myocardial infarction, chronic kidney disease, peptic ulcer, so choose selectively the drug, choose an appropriate drug for that patient, avoid NSAIDs in such patients.
Fantastic. Now, Dr. Rajesh Mahadevan for the last word.
Yes, since I treat the geriatric patients, the caution will be do not take NSAIDs as much as possible. Take paracetamol. You can even go up to 650 milligrams of paracetamol in a single dose, and you have to correct your vitamin D and B12 after age of 50, 55 years of age.
Well, I think I have to thank each one of you for the fantastic discussion and the messages you had for our audience. I think audience have had a lot of great take-home messages, and I do hope that it will help them in their practice, and they'll be able to give greater relief to their patients with much greater safety. I also profusely want to thank the microlabs for who are the academic partners for this event, and they have actually helped the Orthopedic Research Society in our aim to reach out to a larger number of practitioners and overall give the relief to the patients. But like the title says, with safety as the first priority. Thank you very much. I'll now hand over the stage to Mr. Choklingam from Microlab and to give his summary remarks.
Sir, before that, can I request, there are a few questions in the chat box. So would you
Sure.
Shall we take, sir? Yes.
So you are the one who has said the least, so you should answer all those questions.
Very nice. Yeah. Sir, this is Dr. Kumaran from Tamil Nadu, Karur. Doctor is asking, is there any improved result in using diclofenac 2% gel topical?
So, Dr. Sanjeev, do you use the topical gel in your practice?
I use, sir. Sir, I use, sir.
You do use. And so anybody in the panel who does not use this or who has got reservations about this? So that's a very good question. And I think everybody in the panel uses it. I also use. Just a couple of cautions. One, you should never use gel and do hot fermentation on top of that, because that can cause rashes in some patients. And second is, again, you should warn the patient that some of these gels are great counter irritants and they can cause unpleasant sensations or sometimes the skin reactions. So what's the next question, Dr. Manjula?
Dr. Vijay Kumar from Tamil Nadu, Chennai. His doctor asked for low back pain. Is muscle relaxant like chlorzoxazone, tizanidine, or thiocolchicoside, and prednisolone and paracetamol itself, is it enough for low back pain management?
So, Dr. Seema, we'd like to know your opinion.
So I think it's a really good combination if you're using muscle relaxants, newly muscle relaxants like thiocolchicoside, which have come in the market. Along with that, we are using the paracetamol combination.
Yeah, but then it's not a great idea to club steroids with it. You see, I understand the compulsion, because many times, these things have, these diseases have an element of inflammation. Even in osteoarthritis knee, sometimes you can have an element of some inflammation and synovitis for a short period. But steroid is actually not an answer. We have already discussed, particularly, I think, let me take this question to Dr. Chinaraya. Since you treat diabetics, how comfortable you are for anybody using steroids for back pain?
No, we don't recommend for most of these patients. We don't, unless it is acute emergency, we don't use any steroids. Probably, yes, acute low back pain, as you said, locally when they are injecting for the road block or nerve block, probably some of them use local with steroid for locally injecting. Otherwise, I don't think.
There's very little role for oral steroids, and please avoid them. That's not a good idea. What's the next question, Dr. Manjula?
Dr. A.P. Singh Arora from UP Sultanpur. How to manage low back pain in pregnancy and lactation?
So I will ask Rajiv to answer that, because this is a challenge for orthopedic surgeon, and I can also always help him if he wants me to. But Rajiv, you get pregnant ladies with backache. What do? Dr. Rajiv?
I think he's Dr. Channaraya, sir, pregnancy, lactation, sir.
Pregnancy and lactation is one of the conditions where you need to avoid.
Rajiv sir has come, yeah.
Yeah, Dr. Rajiv sir has come in also.
Yeah.
Sir, you
So
can
low back
complete
pain
then.
Let Dr. Chennaraya complete what he's saying, and Rajiv can add to that.
So pregnancy and lactation is a specific situation where you need to avoid drugs which have to be very safe in pregnancy or in lactation. So we need to avoid some of these NSAIDs. Probably paracetamol to some extent we use in pregnancy and lactation. You have to be very careful if they are lactating mother. You have to be carefully choose the drug.
Rajiv?
I think the safest drug is paracetamol, and try to use any NSAID, avoid to use any NSAIDs of prednisolone in pregnant women. So paracetamol.
I think sir has some internet issues, I think.
So it's not at all uncommon to have backache in pregnancy, because obviously the pelvic structure, the entire pelvic cavity is expanding, and there's a stretch of the ligaments in the sacroiliac joint, in the pubic symphysis, and we get patients with severe pain. What I tell them is that at this point of time, the priority is pregnancy, and even if you are suffering from tuberculosis, we would like to, unless it's suppurating, we don't want to confirm a suspicion. We'll just let you through the pregnancy unless it is something very dire. And in that case, we will not do a CT scan. We'll do an MRI, and then of course we can use the mefenamic acid, or you can use the paracetamol even in pregnancy. Or you can even use tramadol actually in pregnancy for the pain. But the emphasis is more on rest. Take rest, adequate rest during the daytime also, and some local fermentation, and try to see it through because it is going to get over only after the delivery. Rajiv, you want to add anything? I think Dr. Rajiv is having some internet issues.
Yeah.
Dr. Manjula, next
Yeah,
question.
two more questions are there. One is, what is the specific nutrient supplement that can be given to patients with lower back pain?
Lower back pain, Dr. Mahadevan has said that vitamin D and vitamin B12 are the most important ones. The rest are more like placebo. And so that is, we must make sure that the patient is not vitamin D deficient and is not vitamin B12 deficient. It has been emphasized quite soundly by Dr. Mahadevan. And what's the last question?
Dr. Amod Borkar from Goa. What is the opinion of panelist on local steroid injection? And then he also has a second question. Do IRR and SWD help in these patients?
So if you were listening to my presentation, I did say that injectable steroids can be given. Shortwave diathermy and interferential therapy and microwave, they all have some benefit as compared to placebo or no treatment, but they have not been shown to have significantly more relief. The relief is there, but it's not statistically significant. But remember, at the end of it, as long as it is not something which is likely to harm the patient, even if it works as placebo, I don't mind. You can use these things. The literature is various. It does not support anything if you pay attention to my slides, except for some massage and some acupuncture. Other than that, and a limited period of rest during the acute back pain. The rest of the interventions are really, plus minus. So it's more of your practice. And that's why we are here, so that the audience can benefit from your experience. because the literature as such does not give much support to these as a primary line of treatment, saying that there'll be some magical relief with this. And I showed you the reason, because many of these diseases are self-limiting. The symptoms are self-limiting. You don't know whether they become all right because they would have become all right by themselves, or was it because of hot packs, cold packs, or IFT. But then some literature to support hot fermentation, some literature to support massage, some to support acupuncture. These are the things which help. The others are like equivocal.
Just one question has come in. Should I take it, sir?
Please.
Yeah, this Dr. Ramakrishnan from Madurai. What about dosage of thiocolchicoside in rheumatoid arthritis pain?
So, Dr. Chennaraya? Dr. Chennaraya, there?
You're on mute, sir. Sir, you are on mute.
Thiocolchicide generally we don't use in rheumatoid arthritis pain. Basically, we use the other drugs for pain. It is not indicated as such in rheumatoid arthritis pain, I feel.
That's right. There are conditions. See, muscle relaxant will relax muscles. So, avascular necrosis of the hip or osteoarthritis. Sometimes in osteoarthritis, in certain stages, it can help. But by and large, it will help in the conditions like back pain, neck pain, which are actually predominantly, or even tension headaches for that matter. I think one of our neurologist teachers used to very frequently use muscle relaxants for tension headaches, because after all, it's the spasm of the frontotemporal muscle which causes this pain. So, Dr. Manjula, do you have any more questions up your sleeve?
No, sir, no more question. Thank you so much. Really, it was wonderful listening to all of you, and I'm sure all the delegates were really benefited. It will help them in their day-to-day practice, ultimately for better patient management. Thank you very much, sir. It was wonderful. I hand over to Mr. Chakulingam and Mr. Girish to do the final vote of thanks. Over to you.
Yeah. So very good evening, sir. It is our great honor and privilege to have you as a panelist and moderator. And special thanks to Orthopedic Society for giving this opportunity to give an academic support, and Professor Dr. Rajesh Malhotra for his wonderful lecture. And I also thank all the panelists, Dr. Rajesh Magadevan, Dr. Chennaraya, Sanjeev, and Dr. Seema Rani, and Dr. Raji Raman, accepting our request and the busy schedule they could able to make it and contribute this learning. And also I thank all the doctors who attended this program in the busy schedule. And I would like to also highlight that Microlabs always been forefront bringing a lot of academic initiative under the Micro Knowledge Academy. One of such initiatives is Fever Foundation. And also we are having us, we have our medical director, Dr. Manjula Suresh, and always in forefront in supporting any academic initiatives or paper publication, etc. Having said that, Microlabs is also, most of you know that we have got presence in more than 50 countries. And also we are also making a lot of effort to bring a lot of first-time India molecules. We will definitely partner with you on all the academic support and any product innovation. Thank you very much. Over to Greece.
I think I don't want to repeat the things to Kalingam. Thanks for taking it up. Otherwise, of course, on behalf of Microlabs, my high regards to Dr. Rajesh Malhotra for accepting the invitation and spending his valuable time with us, and all the eminency of panelists. And this is, of course, the discussion which is having different specialties coming into one forum and addressing the queries of the doctors. And also, I would like to congratulate all the doctors who have been connected, all the healthcare professionals who have been connected with us in Zoom. I understand that this is a busy schedule for their practices. And also, I think some other doctors have been connected with our YouTube Connect. I think there is multiple connect we are given this time. And this panel discussion is definitely been boosting us that, what are the future programs we should be going ahead with the knowledge sharing platform. So thank you so much, sir. And thank you everyone for this connecting.
Thank you. Thank you
Thank
so much.
you very much, everybody, and have a nice evening. It was a pleasure to interact with you all. Thank you very much.
Thank you, sir. Rajesh.
Thank you, Rajesh, sir, for excellent moderation.
Thank you all. Yeah.
Thank you so much.
Thank you, Manjula Madam, for this wonderful coordination.
Yeah, sir, thank you. It was really wonderful. Happy Dasra to all of you, all the delegates and the panelists.
Thank you.
Thank you.